This is a Greek tragedy, but we're not talking about today. It's bladder and renal disorders. Today's talk starts with the just most basic thing you could probably think of in terms of renal pathology, and that is glomerulonephritis. What a word! Do we remember the glomerulus from A and P? That little kind of circular filtration area right before what's in the blood then gets filtered into the nephrons, the descending loop, the loop of Henle, the ascending loop, filtration in and out and in and out. And the kidneys do crazy things. They let stuff out. They reabsorb. They let it out again. They reabsorb. Can they ever make up their mind? It all starts with the glomerulus, doesn't it? Yeah. And in glomerulonephritis, that term indicates that it's the glomerulus where there's a problem. The nephron, the neph always means kidney or related to the nephron, and itis means inflammation. In glomerulonephritis, we have inflammation at the level of the glomerulus within the nephron, within the kidney. That's it. If you hear the term Goodpasture syndrome, that's a common term for an autoimmune disorder causing or manifesting as glomerulonephritis. It's not the only thing that causes or can cause glomerulonephritis. A strep infection, as a consequence of the infection, can cause glomerulonephritis as well. Sometimes we just don't know the autoimmune preceding mechanism that initiated the glomerulonephritis. When patients have this, they can be hematuric. That means blood is present in the urine. In addition to that, if the glomerulus can't filter things, then fluids may not be filtered as well. So people can be edematous or fluid filled. And if there's more fluid in the vascula, they can be hypertensive. Both of those probably make intuitive sense. Now, if any inflammation goes on too long, scarring can be a result. So think about it at the level of the glomerulus. If the glomerulus is inflamed over not a short period of time, but a long period of time, does it make sense that scarring may occur and people may get irreversible long-term kidney damage? Here's another term to add to your renal pathology vocabulary: nephrotic syndrome. In nephrotic syndrome, this term is used clinically whenever the glomerulus is damaged and allows protein to leak out. That clinical term is proteinuria. When protein leaks out, you're then losing protein in the blood. Did you know that protein in the blood is one of the major components to oncotic pressure? That pressure that keeps fluid within your vasculature. If you lose protein in the vasculature and you lose that force holding fluid within the vasculature, does it make sense that fluid can leak out? Now, nephrotic syndrome itself is not a pathology alone. It's always secondary to another source. When a patient has nephrotic syndrome, you as a nurse have to think, A, what's the potential source, what's going on, and B, what are my patient's electrolytes? And by that I mean sodium level, calcium level, potassium level, chloride level. What are those things doing if the kidney can't properly filter things? In addition to that, and probably even more basic, if the kidney can't filter the fluid out of my blood, what's the fluid balance for my patient? Polycystic kidney disease has one of those names where you can kind of guess what's going on just by the name. I love those diagnoses! In polycystic kidney disease, patients have an autosomal dominant genetic condition that potentiates the growth of cysts, largely in the kidney, but in some patients, those cysts are not contained only to the kidney. The other thing to consider or to know about polycystic kidney disease is its potential clinical silence. And by that I mean some patients with certain genetic variants of the disease will actually live an entirely asymptomatic life and perhaps never know they had polycystic kidney disease. For those in whom the cysts are symptomatic and potentially destructive of kidney function, these people will eventually need medical renal replacement therapy such as dialysis and perhaps kidney transplantation, which we'll talk about briefly in just a little bit. So what kind of things can cause kidney injury? Well, when you are working with patients who have kidney injury, there's a couple different things you may see documented in their medical record. I'll give you an example. One thing may be something called pre-renal failure. Weird. The terms pre-renal, intrarenal, and post-renal just designate where anatomically the source of the kidney failure came from. Pre-renal, for example, typically will indicate a patient that is dehydrated and simply not delivering adequate hydration to the kidneys for purposes of filtration. Intrarenal, by contrast, could be someone who has some kind of blockade or disease of the kidney itself. By that logic, post-renal failure would be renal failure that ensues by someone who has some obstructive disorder, blockade, or disease that is down south, past, distal to the kidneys. When you're working with patients with acute kidney injury and you're trying to think of the pathology of that injury, you're also trying to consider at the same time what the status is of that kidney, what its health is, how much filtration can that kidney actually do. One of the things you will consider for these patients is their creatinine level. Creatinine is a metabolic byproduct of skeletal muscle metabolism. Starts off as creatine, broken down into creatinine, and leaves the body. It's also one of the main markers that we use as a proxy to show us how well or unwell the kidneys are able to filter the blood. When you're working with this population of patients, be aware of the fact that you will measure creatinine both by blood and many times by urine as a measurement of what type of global kidney function these patients have. Acute kidney injury, thankfully, potentially reversible. Find the source, take care of it, the kidneys get tuned up, and they're happy. Acute kidney injury oftentimes follows severe prolonged hypotension, hypovolemia, and in that clinical setting, the clinical picture leads to dehydration. In addition, nephrotoxic agents, such as certain antibiotics, can also cause acute kidney injuries. Don't be fooled if you see the term renal insufficiency on a patient's chart. They just mean kidney injury. Same type of thing. It can be tuned up. Acute kidney injury is, as the name implies, typically a quick process. So as you bring these patients in and you work with them in the hospital setting, you're trying to figure out what's going on. It's helpful when you have blood work on them from, say, an earlier time period, and you can look at things like blood urea nitrogen level and creatinine and potassium and actually measure their urine output. Oliguria is the clinical or medical term for a reduced urine output. In these patients, it would not be uncommon to see a heightened level of blood urea nitrogen. The other clinical term for that is azotemia. Kidneys that are not filtering allow excess nitrogen to accrue in the body. We just discussed creatinine. In addition to that, kidneys that are not filtering out the blood can accrue potassium in the body as well. This becomes very concerning when we're thinking about our hearts And the three electrolytes that our heart mainly uses to pump: calcium, sodium, and potassium. Potassium is very important to create the depolarization and repolarization actions of cardiac myocytes. Pre-renal causes of acute kidney injury. Pre-renal pathologies, things that can go wrong to deprive the kidney of its necessary blood flow. Hypovolemia, not enough blood volume. Maybe you have decreased cardiac output. Maybe the heart isn't pumping enough blood out and then depriving the kidney of blood flow. Maybe the blood vessels and the vasculature, especially in the peripheral vasculature, have dilated so much that blood is pooling. There's not enough blood returned back to the heart, and then subsequent to that, not enough blood returned to the kidneys. Maybe there's some type of vascular obstruction just before the kidneys. Still falls under pre-renal causes of acute kidney injury. Contrast pre-renal with intrarenal acute kidney injury. How about renal ischemia from a loss of blood flow, atherosclerosis, plaques right inside the kidney, blocking blood flow, causing ischemia, causing renal tissue death? What about medications we know that are nephrotoxic? I've given them. You will give them. You will monitor a patient's BUN and creatinine when patients are getting nephrotoxic drugs. What happens if you see a spike in those two blood levels? Your patient may be developing an intrarenal cause of acute kidney injury. What happens if the kidney tubules are just getting all clogged up with a whole bunch of cellular waste and cellular debris? That too can be a cause of acute kidney injury, an intrarenal cause of acute kidney injury. Now, pre-renal and intrarenal definitely account for the majority cases of acute kidney injury, though these are certainly the smallest percentage of the AKI cases. In this setting, benign prostatic hypertrophy, I hear it's more common in guys. Prostate cancer, I hear it's more common in guys. And renal calculi or renal stones. We'll discuss those in a few minutes. Those are also called, the medical term for that is nephrolithiasis. So you're suspecting that acute kidney injury is the pathology that you're dealing with here, but what kind of diagnostic studies are you as the nurse going to see to help confirm that diagnosis and then be more suggestive with regard to what that pathology is? Well, the first thing that's going to start is a general urinalysis, a UA, and that's going to give a whole heck of a lot of information with regard to what's going on in the urine constituents, and what it can and cannot filter. But in addition to that urinalysis, there's going to be blood work as well, because the blood work's going to help also to kind of corroborate the findings of the UA, what can and cannot be filtered. Another common test that you may see done is a 24-hour creatinine clearance. This gives a very specific indication of how well the kidneys are able to filter out the blood. You can draw blood for creatinine, but you're only getting a snapshot. A 1-second little look into kidney filtration. Want a movie instead of a snapshot? Get a 24-hour creatinine clearance. That'll tell you over time what kidney filtration is doing. Just like every other part of the body, kidneys can be scanned as well. Ultrasounds, CAT scans, blood flow scans, renal angiograms are the other names for that. All of these are done to help try to figure out one pathology versus the other. And the general idea here is when you're thinking about renal pathologies, diagnostic studies are done to help you rule in or rule out what you think is going on. Now, your med-surg class will get into this in more detail. I'm just going to treat it really lightly. Generally speaking, when it comes to renal failure, especially acute renal failure, the treatment is to hydrate. 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 Doesn't that sound easy? Hey, what about my patients who have renal failure and I notice their blood potassium levels creeping up and creeping up and creeping up? What do I do? Ooh! Step 1. Get an EKG! An EKG is a diagnostic test to look at the heart's electrical activity. You might want to put that one in your notes. Potassium is one of the main minerals that the heart uses for the depolarization, repolarization of the cardiac myocytes. When potassium goes askew, hypo or hyperkalemia, dysrhythmias or irregular heart electrical activity are one of the fears. So, hey, what if my patient, doesn't get better? What if, the acute renal failure just kind of progresses to something bad, something bad, really bad? Well, if it gets really bad, then we might be talking about a dialysis situation. And we'll talk in just a second about hemodialysis versus peritoneal dialysis. Chronic kidney disease, depending on how you want to talk about it, involves progressive, reversible loss of kidney function. And again, it ain't quick. It's not acute, it's chronic. It's over years. It has stages, and if you work with this particular population, you will see these kind of stages of pathology. This is the type of thing that you would commonly see in patients, say, with diabetes and hypertension, two pathologies that we know are very taxing on the kidneys. These people, over the long term, do develop slow but steady declines in their glomerular filtration rate, GFR. The interesting thing about chronic kidney disease to me is that we can lose a lot of our kidney function before we're in it. It's amazing. There's a lot of reserve built into us. Thank you. Thank you, kidney. Thank you, kidney. I love you guys. You're so cute. Oh, and they're ticklish, too. The two most common causes of chronic kidney disease are hypertension and diabetes. One of the things I always mention pathologically with regard to chronic kidney disease is this idea of uremia. If you look at the picture here, you can see about 18 million different clinical manifestations of a patient with chronic kidney disease. And all of them stem from a person's body not able to filter out waste products. It all stems from that. Uremia is the clinical term for the accrual of cellular waste in the presence of chronic kidney disease. Matter of fact, one of the most interesting clinical manifestations of uremia is this thing called uremic frost. And uremic frost is, as the name implies, this kind of crusty, frosted look to the skin from the accrual and deposition of cellular waste within the dermis and epidermis in patients with chronic kidney disease. The workup for chronic kidney disease patients really isn't all that different from those with acute kidney injury. After you talk to these patients and get a good history and do a physical exam, you're going to get some laboratory tests that help rule in or rule out different things. And these lab tests are going to be kidney focused. So the urinalysis, people are going to look at the urinalysis for how well or not well the kidneys are filtering the blood. Maybe there's stuff in the urinalysis that isn't supposed to be there. Protein should not normally be in a person's urine. Red blood cells should not normally be in a person's urine. In addition to that, how well are they filtering out their electrolytes and keeping those things then in balance with the rest of the body? Blood urea, nitrogen, creatinine, electrolytes, calcium, phosphorus, their hemoglobin. And of course, kidney scans to try to visualize if there's some type of identifiable pathology. Renal replacement therapy. All it is the fancy word for dialysis. That's it. Shh, don't tell anybody. Renal replacement therapy is an umbrella term that can mean either hemodialysis, kidney transplant, peritoneal dialysis, or slow hemodialysis. Why would we do slow hemodialysis on someone? In some people, hemodialysis is taxing on the body. So doing it more slowly allows the blood to be cleaned, but also allows avoiding some of the negative consequences of hemodialysis. For example, hypotension.
Oh, but I need some time off from that emotion. Time to pick my heart up off the floor. Oh, when that love comes down without devotion. Well, it takes a strong man, baby, but I'm showing you the door. 'Cause I gotta have faith. I gotta have faith. Because I got to go for faith.
As you read through this slide, I just want you to think of two things. You're going to read what is dialysis, you're going to read principles of dialysis. You're going to read under diffusion, the movement of solids from an area of greater concentration to an area of lesser concentration. Under ultrafiltration, you're going to read about the movement of fluid across a semi-permeable membrane in response to an osmotic gradient. I'm kind of hoping you think to yourself, dude, didn't we learn about diffusion and osmosis in high school? Because you did! And here it is back again. Dialysis really isn't all that magical or mystical at all. It is literally just the application of stuff we learned about in high school. Diffusion, osmosis. Woohoo! So just to kind of hammer home the general principle of dialysis again, when you're dealing with kidney patients and they're in chronic renal failure and they have to go through some form of dialysis, diffusion and osmosis are the main guiding principles by which waste products are taken out of the body. If you work with this population of patients, you will constantly be seeing varying levels of glucose in the dialysate. That's the fluid that is used to draw off wastes from the blood. And those different concentrations of glucose are what helps to create the osmotic gradient and achieve the pull of fluid from the blood. Now, peritoneal dialysis is cool because you can do it in your own home. Oh! And that is nice. That is why people choose to use peritoneal dialysis. And matter of fact, you may see on your patient's chart the acronym CAPD for Continuous Ambulatory Peritoneal Dialysis. In peritoneal dialysis, the dialysate is infused into the abdominal cavity. Right there. What did I eat today? And once in the abdominal cavity, the abdominal vasculature acts as the semi-permeable membrane by which fluid and waste gets filtered. The dialysate sits in the abdominal cavity for a period of hours, and then once it's done its filtration job, that fluid, that dialysate, is drained out of the patient, and clean fluid, clean dialysate, is put in. And that process is called an exchange. Contrast peritoneal dialysis with something called hemodialysis. As the name implies, you're dialyzing, but you're using the blood quite directly, rather than using the abdominal cavity. In hemodialysis, patients are either equipped with kind of a surgically implanted site catheter, some type of access device, or their own vasculature is used to specially form an area, either a graft or a fistula, those are the two terms, to specially form an area that a dialysis machine can be hooked up to, typically using two needles. One needle to take off the blood, run it through the hemodialysis machine, and then a second needle to return the clean blood back to the patient. Hemodialysis works exactly the same way as peritoneal dialysis. When the blood is taken off, it is then sent through a filtration cartridge. And the filtration cartridge does the exact same job that the peritoneal dialysate did. It filters out wastes and fluid, and then sends the clean blood back to the patient. Hemodialysis is a lot busier than peritoneal dialysis because people got to show up to a clinic 3 times a week for what's typically a 4 to 5 hour treatment. That's busy. Takes a lot of work. You got to leave your home, and it's challenging. The advantages to it are you're not doing it every single day. So when you leave the clinic, you're done. That's it. You don't have to worry about an exchange. There are pros and cons to both hemodialysis and peritoneal dialysis. Peritoneal dialysis has complications. One of the most serious, which has to be monitored for all the time, are peritonitis, infection of the lining of the abdomen because of the exchanges and the connection of the fluids to the abdominal catheter, and the fact that although patients are taught to do it in an aseptic fashion, that's really hard to do every single time, day after day, day after day. Hemodialysis has complications as well, such as hypotension or low blood pressure from perhaps drawing too much fluid off. Patients can get muscle cramps from that fluid removal as well. And then the more serious complications are sepsis, so blood infection, just by virtue of the nature of hemodialysis, and hepatitis, most specifically hepatitis C. And if you're thinking to yourself, wait a minute, man, it's 2020. People cannot get hepatitis C from having hemodialysis, you're actually incorrect. Now, while the numbers of cases of hepatitis C do appear to be going down because of universal precautions, infection control, and all of that, patients that are on hemodialysis and are going to the clinic 3 times a week and getting all of that done, by about the 10-year mark, their incidence of hepatitis C development markedly higher than, say, that of the general population. So we know that this type of medical activity does infer greater risk for hep C transmission. But in addition to that, these patients have diseased kidneys, they're not making erythropoietin, they're potentially getting blood transfusions, there's risk in that as well. So there's other things that factor into it. Kidney transplantation, one of the treatments for chronic kidney disease. Now, in a pathophysiology class, I don't focus that much on treatments. Unless the treatments themselves contain potential pathologies, then it kind of intertwines real nicely. In kidney transplantation, selecting who gets a kidney is really important. Why give a kidney to somebody who may not live long enough to utilize it? Or a person whose vasculature is so crummy that they could really just ruin the vasculature to the new kidney? So recipient selection is an issue. Also, if somebody has cancer, especially widespread, aka metastatic cancer, probably not a good idea to give them the kidney. Nah, probably. Really bad cardiac disease, extensive vascular disease, other infections. There's other stuff that would make people not necessarily a good kidney transplant recipient. Kidney transplantation isn't a walk in the park. Even after your patient gets their kidney, there is risk for subsequent or consequent pathologies after the transplantation. The most feared of which, in my opinion, is rejection. The patient's immune system attacks the transplanted kidney. To prevent this, matching is done. Any kind of transplantation involves matching of some type. For organ transplantation, HLA antigens on the surfaces of cells need to be matched from donor to recipient. There is different kinds of rejection, and they are subdivided based on the timing in which they occur. Hyperacute, acute, and chronic. Hyperacute, bad, but most of the time preventable. Therefore, clinically, you don't see that as often. Acute and chronic, however, more common. Acute can be treated with something that suppresses the immune system, for example, steroids. You're going to hear a lot about steroids in your pharmacology class and other medical intervention focused classes. Chronic rejection, on the other hand, does not respond as well to immunosuppressants as acute rejection does. This is a very slow, smoldering kind of rejection. Think of it as a type 4 hypersensitivity. And the medicines just don't work that well. It's almost subclinical, and it can be years later when the chronic rejection finally amounts or amasses to a point where the transplanted kidney is no longer functional. Well, what fun would talking about kidney transplantation be if kidney transplantation didn't just contain all these other possible pathologies, including rejection, and holy moly, what a complicated process! After a person is transplanted the kidney, they can get an infection. Immunosuppression does not help this, by the way. Patients that are on immunosuppressive drugs, when they suppress the immune system, the risk for a potentially serious infection goes up. For reasons that are not entirely clear, patients who receive kidney transplants seem to accelerate atherosclerotic vascular disease. Isn't that weird? So this is observational data. Now, we all have atherosclerotic disease going on. Something about the kidney transplantation process, perhaps related to maybe not the transplant, but the immunosuppression itself, accelerates that process of atherosclerotic vascular disease. And there isn't much we can do about it other than advise for a heart-smart diet. Another complication of kidney transplantation is immunosuppressive specific, and that is the development of malignancies, especially lymphoma. Most common one is actually named for the process going on, and it's called post-transplant lymphoproliferative disorder, PTLD. Now, don't think that corticosteroids are benign drugs. When you learn these things in pharmacology, you'll learn that while they have one intended effect, they have a gajillion side effects, and you will learn to identify all of these very quickly because steroids are used everywhere.